Friends, colleagues, ladies and gentlemen, welcome to the 16th TechNet Conference session entitled The Future of Country's Cold Chain System, Achieving Cost Efficiency in Managing Storage of Primary Healthcare Commodities. I would like to start by introducing myself. I'm Maricel Castro, and I'm part of the Vaccine Supply Chain and Logistics team in the EPI of WHO headquarters. COVID-19 has affected the immunization program and supply chain systems in many ways. It disrupted routine immunization services, caused postponement of mass vaccination campaign, interrupted supply and delivery schedules both nationally and internationally, and led to a surge of diagnostic and therapeutic products requiring refrigeration. All of this puts strain on the existing cold chain capacity and altered the supply and stock balances. Even before the COVID-19 pandemic, some countries are already facing challenges storing their life-saving essential health commodities, such as oxytocin, insulin, and HIV treatment and test kits, which require cold chain to preserve their efficacy. During the first peak of the COVID-19 pandemic, this challenge has become more visible due to the additional demand to store the COVID-19 diagnostic and therapeutic products in the cold chain. The Global Immunization Supply Chain Network received reports on the increased use of the existing EPI cold chain equipment to store these additional temperature-sensitive products. This situation called for WHO and UNICEF to update the previous 2015 joint statement permitting for the integration of other health commodities into the vaccine cold chain system, if feasible and accomplished in a safe and efficient manner. The new joint statement provides additional guidance to ensure safe, effective, and sustainable implementation of integrated supply chain for temperature-sensitive essential health commodities. In this session, we will discuss the objectives and the key recommendations contained in the joint statement, and will share stories of countries that have adopted an integrated cold chain and supply chain strategy. We will start the session with an overview of the WHO-UNICEF joint statement, which will be presented by Ms. Michelle Seidel. She's the cold chain specialist on the Immunization Unit Health Section Program Division of the UNICEF headquarters. Then I will continue by discussing the key considerations for countries planning to implement an integrated cold chain or supply chain. Next, we will have Dr. Tariku Berhanu, the Immunization Officer in UNICEF Country Office for Ethiopia. He will share Ethiopia's approach in integrating immunization supply chain in the wider health supply chain. The final presentation will be delivered by Dr. Monjurul Fuad, Deputy Program Manager in EPI Bangladesh, Ministry of Health. He will share his country's experience on supply chain integration in the context of information system. Please note that audience mics are put on mute and videos are off during the presentation, but you may post your questions in the chat box. You may or may not put the name of the speaker whom you wanted to address the question. Thank you, and I will now give the floor to Michelle.
Thanks, Maricel. So as you heard, Maricel gave a good reason as to the background of the statement. And on the 11th of March, WHO declared COVID-19 a public health emergency. And we saw that immunization due to social distancing measures in countries started slowing down. In addition to that, we also saw that countries started setting up laboratories for supporting testing of COVID-19, and due to the requirement of cold storage for reagents and other lab supplies, we saw that there was a large surge of national and subnational cold chain facility requirements as well. In addition to this, we also saw that there was a cessation of campaigns, and unused campaign vaccines started to stockpile. This, together with disrupted delivery schedules and the need to store other heat-sensitive health commodities, including all the COVID-19 diagnostics and therapeutic products, significantly challenged the existing cold chain capacity and altered the supply and stock balances. So in the next slide, we have a look at the purpose of the joint statement. And that was essentially to reiterate the value of safe, feasible, and cost-effective integration of temperature-sensitive health products into the EPI cold chain system. As indicated before, this was something that was advocated for in 2015, but we felt the need to update this guidance and advocate for it more strongly, as countries had greater need for this. It also highlighted that integration as a practical solution to address cold storage need of other essential health commodities. It highlights the important considerations before adopting an integrated cold chain strategy. It also recognizes the associated risks and offers some practical solutions to mitigate these. And then it provides reference to existing guidance, tools, and mechanisms to design and implement a safe and efficient integrated cold chain system. So there were some overarching general recommendations, and it was one, that it is permissible to use the EPI or vaccine cold chain system for storage and transportation of appropriate temperature-sensitive pharmaceuticals, provided that the labeling and separation to distinguish vaccine from non-vaccine products is consistently adhered to. That two, the WHO and UNICEF guidance on safe integration must be followed to ensure the quality and potency of all health products in the shared storage space. And three, the decision to integrate should be guided by a risk-benefit analysis and cold chain capacity assessment together with an integration plan. So now I hand over to Maricel to go through some of the specific guidance that we developed for considering an integrated cold chain strategy. Maricel, over to you.
Thank you very much, Michelle. As already mentioned, an integrated supply chain, including cold chain, has many benefits. This can be maximized by ensuring that all safety and precautionary measures are in place, especially at the service delivery points, to ensure system efficiency and functionality. The joint statement provides guidance for countries to safely and effectively implement an integrated cold chain and introduce some tools useful for planning and system design. But before a country decide to integrate, they should first ask these questions. Which non-vaccine health products require cold storage? And is it feasible to safely integrate the vaccine and non-vaccine temperature-sensitive health products in the existing supply chain? Is there sufficient cold chain capacity to accommodate all the appropriate health products in the cold chain? And what modifications or adjustments in terms of guidance, infrastructure, information system, etc., are needed to ensure efficiency of an integrated cold chain? So from here, I will discuss the specific recommendations of UNICEF and WHO on the 4 key areas, namely the cold chain capacity assessment, integration and documentation, safety consideration, and the communication and coordination. With regards to the cold chain capacity assessment and forecasting, countries are encouraged to assess existing capacity and feasibility of integration using available data on cold chain inventory or if they have latest EVM assessment. UNICEF and WHO have some tools that can be used for this purpose, such as the cold chain capacity gap analysis tools. And you can actually find the link for most of these tools in the WHO, UNICEF, and TechNet websites. The inventory of all available and functional government and private cold chain facilities should be updated to understand the available capacity, including surge capacity, both in and outside the immunization program. Maximizing the use of all available functional WHO pre-qualified cold chain equipment to store other products is encouraged. And where capacity is limited, countries are encouraged to prioritize storing vaccines in the API cold chain. And for future use, where the capacity is limited, countries are encouraged to prioritize to ensure that they will add 25 to 30% more cold storage space when investing on new cold chain equipment. With regards to integration and documentation, wherever safe and feasible, countries are encouraged to consider integrating and in the storage and transport of temperature-sensitive health products such as oxytocin, insulin, and HIV, and COVID diagnostic and therapeutics in the API cold chain. The integration should be comprehensive, and it should extend beyond the physical storage, such as the recording, reporting, and monitoring of all supply using the same equipment or facility to ensure proper management and quality of the products. Managing the integration is a shared responsibility. All concerned program managers and supply chain officers should be involved in all phases of the integration process, including the updating of all relevant guidance, SOPs, and information systems. Countries are also advised to allow enough transition period to gradually scale up their implementation to ensure that system will work efficiently and safely. Now, for safety consideration, this is where the most concern is. So the safety of the approach must be ensured at all times. Preparing the staff to responsibly implement an integrated approach is key to its success. Therefore, all concerned staff should be trained on the updated SOP and safety guidelines to ensure smooth integration and mitigate against products being mistaken one for another. And during storage and transport, each product type should be kept in the original secondary and tertiary packaging allocated by the manufacturer. And they should have allocated a dedicated and a well-labeled space within the shared cold chain equipment to keep non-vaccine products and vaccines and diluents safely separated. If allotting dedicated space for each product is not feasible, countries are encouraged to adopt solutions to quickly and clearly distinguish vaccines from other products, such as placing clear and ambiguous visual cues on the external packaging. Countries should consider modifying the supply and distribution schedules where and when required to avoid excess burden on their cold chain. Monitoring and supervision must also be in place in order to make sure that proper adherence to the 5 rights of medicine and vaccine administration are complied with, especially at the service delivery points. As part of the risk mitigation, countries are also urged to strengthen the AFI surveillance system. So for coordination and communication, countries are encouraged to develop a communication strategy to ensure all concerned staff are aware of the relevant guidelines and SOPs. Make sure that their roles and responsibilities are clearly written and that they have access to the relevant tools, job aids, and information materials to make them comfortable and confident in implementing the strategy. Countries are encouraged to establish a coordination mechanism for timely and effectively respond to incidents of AFI. And finally, countries are encouraged to document experiences and best practices as evidence for future policies and guidance. So I will stop here. Thank you, Michelle, for this presentation that you jointly shared with me. And we will now listen to Ethiopia's experience from Dr. Berhanu.
Good morning, good afternoon, and good evening, wherever appropriate. My name is Tariku, as introduced by the moderator. I'm going to share you the Ethiopian experience and integration of immunization supply chain into the wider health supply chain. I'm waiting for the slides, I think. Okay, my presentation outline has background, some policy issue, rationale, process, and key lessons at last. EPI program in Ethiopia offers 11 antigens, including the most recent addition, rotavirus, IPV, and HPV. The system, actually, the old system broadly followed the administrative structure, region, zones, and so on. And it had about 6 levels contributing to inefficiency and made it difficult to achieve visibility. Further, ownership and responsibility spread over different entities like regional health bureaus, zonal health departments, and Warada health offices. The supply chain for other essential medicine have undergone transformation starting in 2005 with a pharmaceutical logistics master plan. Following the master plan, this plan led the creation of an autonomous FMOH agency, which was called Pharmaceutical Fund and Supply Agency. Now, the name has changed into Ethiopian Pharmaceutical Supply Agency. PFSA was responsible for the entire public sector healthcare supply chain, including the design, implementation of an integrated system and the integrated pharmaceutical logistics system, what we used to call it IPLS, delivering a range of priority health commodities, HIV, family planning, malaria, and maternal and child health commodity to more sales facility and delivering these supplies up to the health facilities. And PFSA benefited from the significant investment in infrastructure, system, and human capacity. And the rationale was like, PFSA status as a federal agency would make it easier to eliminate level in the supply chain to enhance data visibility and thus applying supply chain efficiency. And having a single agency responsible for most aspects of the vaccine supply chain would improve accountability for system and for system performance. And by leveraging FSA infrastructure, systems, technology, and human capacity, supply chain sustainability and performance would be enhanced with several new expensive and large volume vaccine being introduced. As mentioned above, that there was a recognition that the new approach was needed for the supply chain and reluctance to invest in the older system, the current system at that time, without major changes. So the integration process starts with a plan, FMO, which was prepared, a plan which had procurement of cold rooms, cold vans, relocation of existing cold rooms to KFSA hubs, design and implementing of an LMS, development of SOPs and training, recruitment to be this had been completed at the end of 2015, and the phasing strategy was employed in the new distribution system with PFSA, delivering initial immunization supplies from hubs to zones, and next phase was from hubs to Warada by passing zones, and later hubs directly to health facilities that are easily accessible. And the latter plan was developed, as I said, in June 2014, and followed by the phasing approach, identified three initial regions to test this program, and the three locations were Bahar Dar in the northern part of Ethiopia, Jimma, western part of Ethiopia, and Mekele up in the northern part of Ethiopia, where transition would begin first with PFSA taking over storage and distribution of vaccine from the regional health bureau, where the old facility existed, and in some places where zonal health departments managing the cold rooms. So this actually helped to increase the cold room capacity from 1,300 meter cube to 4,000 cubic meter, and a freezer room from 45 to 400 meter cube. This actually added from. And ISH and other Kikul health community also share the storage, transport, leadership and HR to enjoying economic scale. Added over in the system, other than the hubs and central store, over 9,000 solar direct drive refrigerator into the level system, which means that at the response level. And of which that's 6,000 SPD procurement project funded by the government, and the procurement process used for these projects adopted for the CCOP implementation, which has actually extended warranty and after sales service modality about 10 years from the starting from the procurement, from the shipments. In 2018, the country further developed an overall immunization supply chain management and incorporated the missed part, and HR development and leadership have been given due consideration in this document. The key lessons further priority out of this endeavor were actually the situation was complex and country have difficult supply chain characteristics, number of levels, frequency of supplies differ, and type of vaccine being used differ. And also, we don't know what the future brings. Example, COVID-19 vaccines to come, so we don't know the size and requirements. Therefore, mode of storage and distribution is differ, like private or government, air, truck, and etc. Further type of pharmaceutical product requiring refrigeration varies from country to country. Then under such complexity, prospective adjustment for improving efficiency and effectiveness is difficult or not impossible. So in such scenario, what we can propose is process which can be agreed by most partners. We cannot satisfy all, but at least the majority, if the majority agree on the process, then the supply chain system design comes in, and what Ethiopia did in early 2007. These are actually some of the experience that I would like to share to you. This has a reference I used for the presentation. Thank you very much for your time and attention. Thank you. Over to you.
Thank you very much, Dr. Tariku, for sharing your experience in the integration in Ethiopia. And now let's hear from Dr. Fuad from their experience in Bangladesh.
Hello, everyone. Greetings from Bangladesh. I'm Dr. MD Monjurul Fuad, Deputy Program Manager, Field Service EPI, Ministry of Health and Family Welfare, Government of the People's Republic of Bangladesh. I welcome you all on our presentation on integration of EPI supply chain, including CCE inventory in the DHIS2 platform, Bangladesh. Bangladesh is a country with 170 million population. Our birth cohort is 3.7 million. As per our last coverage evaluation survey 2019, our DPT coverage is 39.4% and measles coverage is 88.3%. EPI launched on April 7, 1979 and intensified both in rural and urban areas as universal child immunization from 1985. And the coverage increased from 2001, and now our fully vaccination coverage 83.9%. We have 64 districts, out of them 58 districts have fully vaccination coverage more than 80%. Bangladesh has 3 tiers in EPI supply chain system comprising 1 central store, 64 lowest distribution point, and 692 service points. At central level and the lowest distribution point, all vaccines are stored at +5 degrees centigrade, except for the OPB, which is stored at -15 degrees centigrade. At service point level, all vaccines are stored at +5 degrees centigrade. Bangladesh is the largest implementer of DHIS2, including both aggregated and individual reporting. All the health programs reporting done through DHIS2, including EPI supply chain and cold chain equipment inventory. We started routine we started routine API recording through DHIS2 in 2013. In 2014, vaccine and logistics stock reporting initiated. Full vaccine and logistic management information system implemented in 2016. In the same year, cold chain equipment inventory implemented through DH2. Monitoring dashboard for national and subnational level started in 2017. In 2019, immunization e-tracker started. EPI supply chain and CCEI implemented at all three EPI supply chain level. And the frequency of reporting for EPI supply chain is quarterly for the national and monthly for the lower distribution point and service point. CCEI reporting is real time when there is any changes in cold chain equipment status. Data sets of EPI supply chain are vaccine and logistics stock report for all three levels, indent form for vaccine and logistics for lower distribution and service point, supply form for vaccine and logistics for central and lower distribution. Data elements for EPI supply chains are balance, use, damage, receipt, supply, manufacture, lot number, expiry date, and VBM stages. Advantages of the EPI supply chain in DHIS2 is used to aggregate, analyze, validate, and monitor stock balance, supply, receipt, etc. at all levels of the supply system to manage the supply chain. Monitoring of routine EPI and EPI supply chain dashboard in DHIS2 allows to monitor vaccination coverage as well as dropout by sex disaggregated, vaccine wastage, vaccine and logistics stockout, supply, receipt, and demand from the national to service point. Bangladesh is the first country having cold chain information system in DHIS2. It is developed through DHIS2 tracker capture application. Through reporting modules of CCEI, we record temperature alarm, preventive maintenance, repair request, repair complete. Data elements of CCEI are serial number, catalog ID, equipment type, manufacturer, model, year of installation, power source, storage capacity in liter, and WHO specifications. Monitoring of cold chain equipment inventory dashboard in DHIS2 allows to monitor distribution of cold chain per functional status, capacity, repair status, manufacturer, equipment type, PQS or PIS norms, energy source from national to service points, distribution of cold chain equipment, functional storage capacity, liter. So far, the challenges we have encountered are completeness, timeliness of the reporting, accuracy of data entry and use of data, use of DHIS2 by health managers and use of data for decision making, maintenance of device and day-to-day problem solving, capacity of server and upgradation of software, including limitations of some features in DHIS2. But now we are working on these to overcome successfully through conduct multi-stakeholders workshop, training, monitoring, and enhancing the server capacity. Our commitment from program is the prerequisite for successful implementation of DHIS2 integration. Prioritization by Ministry of Health and Family Welfare to have one common HMIS for reporting, coverage, supply chain management, and individual health profile tracking for newborn child and maternal and adolescent. Use of DHIS2 from community to national level for one program make it a success. New and innovative approach welcomed by health managers like app-based monitoring. Using DHIS2 for supply chain management ensured effective monitoring and better planning for health managers and workers. Timely reporting helping for better supply chain management and reduce the lead time 1 to 2 weeks at district level. As per our future plan, individual tracking implementation in 16 districts and 8 city corporations along with child biometric to track all target children, integration with CCEI and temperature monitoring system to establish data-driven supervision, monitoring at all levels. Thank you all on behalf of me, as well as EPI Bangladesh and UNICEF, and wishing a very successful conference of TechNet 2020 during this pandemic, and also thanks to everyone related to this event. Thank you.
Okay, thank you very much, Dr. Fuad. So before I give the floor to Dereje for the facilitation of the question and answer, I would like to give a few minutes to one of the countries that also have a very good experience with regards to integration in the context of stakeholders engagement and system design. So I would like to give Mr. William Musube, officer in charge of the National Medical Store of the Minister of Health in Uganda, to share also their experience with regards to involving all the concerned entities in planning for an integrated cold chain. Over to you, William.
Hello, thank you for that, but unfortunately, I've not prepared that presentation. I've just got the information a bit late, but I prepared something different in line with the theme for this work group. That is the future of countries' cold chain systems and how to achieve cost efficiency in managing storage of primary health care. Is it okay that I could share some insights onto that topic, or can I proceed with that if it's acceptable by the moderator?
Yes, please go ahead. You have a few minutes.
Can I share my screen if it's okay with you? Okay. If not, then I can just
yeah, I think it is possible to just speak because I cannot see.
Okay, then. Okay. Good evening or good morning, members. I don't know where we are all on the globe, and you're most welcome to this session. And I'm glad to be part of this work group discussion. I'm going to just share my experience on the theme for this work group, the future of countries' cold chain systems, efficiency in managing storage of primary health care. Beginning with basically I'll be talking about 3 major considerations that can be taken by countries for future cold chain systems. One, how can countries be able to make use of their stock data to make the supply, to make the desired supply chain decisions? For countries to have a very good, efficient management of their storage systems at primary health care, it's very paramount that they use data as we've done in Uganda. What we are doing currently is we are working with the health facility personnel to understand the causes of irregular consumption patterns, and then putting out mitigations to block all the wastages that we're seeing for vaccines. By doing so, we optimize the using. We optimize the use of the cold storage whatever space and reduce the distances of any of us talking, because we do understand that if countries are if the facilities or if countries do order for too much stock, then they will be forced to run much more cold storage space, and running whatever cold storage is a very costly venture. So the more cold rooms or the more fridges that you deploy in managing stock, the more costly that becomes to the country. So it's very, very, very important for countries to understand the data, their stock data, and see how they can use that in planning for their stock requirements. Then secondly, we are seeing that in the future countries will need to use more, they have to use more the new technologies to have a more proactive management of stock. One such technology is, we are now seeing there is more and more use of the RTMDs, the remote temperature monitoring devices. These are now coming, we see very many of them coming on board. But what we need from WHO and UNICEF for them to develop the standards and the guidelines for these devices. We are seeing most of the innovators of these devices don't have any harmonious way of standardizing how the device can help countries, and each manufacturer or each innovator is trying out what they need. So for you to have better management of stock at the primary health care, we will need to have WHO to develop standards for such devices that can send data remotely, so that we can have better use of such data for management decisions. And then there is again talking about goods storage management. You need to have a strong LMIS across supply chains. In Uganda, that has been our strategy, but we have not yet realized the goal of having that linkage of the LMIS across all the supply levels. So that is still a gap, but it's very paramount for you to have a very good management of storage. You need to have a good LMIS system that can show visibility both at the district up to facility level. What we have managed to achieve is the central vaccine store and the district vaccine store. There's that good linkage. There's better visibility. We have got good visibility for those two supply levels. Now, our next level is to move down. How can we add the lower health facilities? Then also maybe if there are any manufacturers who have joined us in this session, how can manufacturers embed stock management applications in their equipment? This is maybe like an innovation that can supplement the manual HMIS tools that we use. If they can, if the manufacturers can embed stock management applications whereby the users at the facility level can from time to time punch in their stock data. Maybe when they receive stock, they can punch it in. When they remove stock from the fridge, they can punch in that application. And then the application can also send reminders when the stock levels have reached that critical level. So that would be maybe some good way of helping the users of these health workers to manage stock at the facility level. And then even for the designers of these applications, if they can take it even further, they can also design the application to send data to a central API depository, so that all these fridges, on top of having the other activities, they can also send stock data to some central depository. So in that way, we can see how basically countries can now make use of their stock data in managing the storage at the health of the primary health care commodities. And then the other area that can improve management of storage at the primary health care can be realized by supply chain redesigning to contribute. Basically, how can this be used to make better throughput of commodities and reduce redundancy of the asset? Because what we are seeing is that most facilities are holding stock, and they are requesting to have bigger capacities of cold chain for fear of running out of stock. Now, and then also for having they have like the uncertainties on how the throughput will be in the future. But once you have the supply chain redesigned and you're sure of the last mile supply of the vaccines and the supply from the central vaccine store, then that can reduce the redundancy of the assets that they have, and meaning that they can now plan better for the actual stocks that they need without really holding too much stock than they would need for each period. Then,
if you can, you have 2 minutes left. If you can.
Okay.
Thank you.
So then the other thing can be through maybe supply chain integration with the wider health supply chain ecosystem. Then also maybe making use of the basic lean process methodologies like the Six Sigma and the like to see how to improve on the storage practices that they have at the health facility level. Then maybe the last one is understanding the drivers and controlling the cost of maintenance. So countries should shift their major focus on preventive and predictive maintenance and reduce on the instances of corrective maintenance. In doing so, they will be keeping their cost of maintenance at a minimum and increasing on the lifetime of the assets that they have. That's what I had to share with this discussion. Thank you.
Thank you very much, William. Now the floor is on Darehe.
Okay, thank you, Maricel, and thank you to the presenters for this very nice overview. It's now time for a Q&A session. As you can see, we have only 10 minutes, but fortunately, we don't have many questions unanswered within this 10 minutes. My suggestion is there are 3 questions which are already raised. One from Sam, Malawi, Patlenan, and then Ridwan. I apologize if I mispronounce your names. So these 3 questions are already responded to by Tariku for Sam, and the other 2 questions by Jahid. But in the interest of, I think, putting this question and answer to the wider group, and with kind permission from the moderator, Maricel, will it be good idea to, since we don't have any question, we repeat these questions and give the floor to Tariku and Jahid to respond more on these questions.
Yes, that's a good idea so that they can expand their response. Thank you.
Okay, thank you very much. So the first question is to Tariku. Tariku, you are around, so you have already responded, but if you can elaborate to the question. The question is, Ethiopia, I might have missed it. Did you face any resistance from the EPI program as you were integrating the cold chain into the main health supply chain system? If so, how did you go about it? Over to you, Tariku.
Okay. Good morning, good afternoon, and good evening to participants and everyone. Yes, we had some resistance. It was not strong as we were actually expected. Some few regions were resisted because they thought that authority would have been taken away from them, because the full circle of supply chain used to be managed by them. So they are afraid of giving this responsibility for the new organization. The new organization, I mean that the health system is there for a decade. I mean, for more than a half century. However, IPSA PFSA was introduced in few years before this activity, this move. Therefore, they brought so many reasons which we had entertained by visiting the managers, and sometimes we go with high officials to advocate the importance, to show them how important to bring all resources together, and also to find out an accountable body that is going to be asked, and also easy to introduce new technology, review, revise, and correct, instead of spreading or diluting the responsibility to around 100 zones and 11 regions. And then pulling all this into one center and 17 hubs was actually this was actually our strategy to reach them, with this, the importance of that strategy. Second, apart from the management, individuals, actually influential individuals who have been in the system for a long time. Some are actually coached many of us. So it was difficult for them to give their baby to some unknown person, because of, affection for their job. And partly they were also afraid of losing their title. But as I mentioned in the text, that we had a series of training and advocacy visits. Therefore, we're able to manage the problem.
Thank you, Tariku.
Response. Thank you very much.
Thank you, Tariku. Yeah. So in the interest of time, and we have 6 minutes more, and I'll give the floor to Jahid to answer the other two questions. And we have one more question for William. So I will give 3 minutes to Jihan to answer these two questions, followed by William to tell us to respond to this question. So quickly, over to you to Jahid.
Okay, hi, good evening. Nice to meet you. So the question is the data updated. Regarding the data update, yes, data updated regularly for the cold chain equipment inventory whenever any changes in the physical inventory or the facility level. And the cold chain inventory integrated in the DHS2 tracker capture apps. So the facility level staff are responsible to update the inventory through the computer system they have available in the facility. And the next question is?
The next question is for cold chain inventory. How and how often the data inserted by health workers at service points? What equipment is used?
I already answered the second one. I missed the first one actually.
Okay, the first one is from Pat Lennon. Impressive use of data in your health system. Are there dedicated staff for data system management to be successful, or is data system management part of everyone's job?
Yes. So the Ministry of Health in Bangladesh, there is a dedicated department for the management information system in Bangladesh. And from national, district and sub-district level, there is dedicated staff for the managing the data system and provide data regularly. For the community level, community health worker is responsible to provide the data in the system. So this is it.
Thank you very much. So from Taria to William, tell us whether health facilities are making use of vaccine forecasting tool when ordering vaccine, bearing in mind we follow the aspect of maximum and minimum stock levels. Over to you, William.
Okay, thank you, Derija. Now, health facilities do make use of the minimum and the maximum. Basically, when they only use this when they are doing their annual quantification. So, but on the monthly basis, they order based on the consumption method. So this minimum and maximum does guide them on basically on the maximum stock that they must order from the district, and the minimum they must have as a buffer. But on a monthly basis, they normally use the consumption method based on what they have used in the previous month. But so this minimum and maximum only works when they are doing their annual quantification. That's how basically we do manage that stock within check.
Thank you very much, William. And I think one other question that was raised by Ian was, may I please ask whether the solar direct drive cold room will be practical value for COVID-19 vaccine storage, and also the ultra low temperature transportation cooler? Probably what I can say for this specific question is that this might not be the right forum for this question. There are other forums which we are going to have after this, maybe the COVID-related forums. Maybe this question could be addressed at those forums. But maybe Maricel could come on this specific question. But otherwise, I don't see any other additional question. And over to you, Maricel.
Okay, I think, as you said, this question is, I think, better be addressed to the other forum. There is a session that deals about this particular topic in the agenda. So I suggest to bring it there so that we can have the expert respond to this. For the meantime, I would like, because we are almost near the time, and I would like to take this opportunity to thank everyone for your presence, for your participation, and for the great questions that you have shared in the chat. And also, I would like to thank all our speakers for their for contributing to this session. So we hope you will continue to follow the other sessions, and have a great day, everyone.
Thank you very much, Maricel.
Thank you very much. Thank you. Bye.